Hey everyone, you ready to dive in? We're tackling some medical research today, something you sent over, ARVD.
Arrhythmogenic.
Right.
Ventricular dysplasia.
Yeah, that. So maybe not a typical Tuesday, but hey, by the end of this deep dive, you'll be practically cardiologists. Well, almost.
And it's a topic worth knowing about, that's for sure. ARVD, it's more common than folks realize, especially in young people.
Yeah, that's what makes it kind of scary, right? Flies under the radar. So before we even get to the research itself, give us the layman's version. What ARVD? Like, explain it to me like I barely passed high school biology.
Okay, so imagine your heart is like a house, right? And ARVD is like this shady contractor came in and started replacing the walls with like cardboard, but only on one side, the right side.
Okay, that's not good. Definitely not up to code.
Right. So that's the right ventricle, a key part of your heart. In ARVD, it gets all messed up with scar tissue, fat, weak spots.
So bad construction job on a very important house.
Exactly. And all those weak spots, they mess with the heart's electrical system. And that's when you get arrhythmias, irregular heartbeats.
Oh, so not just like a little flutter now and then.
Could be, or it could be way worse, like a full-on electrical storm in there.
Yikes. Okay, so we're talking serious stuff.
Yeah.
And you said it's hard to diagnose early on.
Super tricky. See, ARVD, it can be sneaky.
Yeah.
Symptoms, when they even show up, they're easy to brush off.
Wait, so I could have this serious heart thing and just think I need more coffee.
It's not quite that simple, but yeah, fatigue, dizziness, little chest discomfort. People ignore that stuff all the time. That's why we're talking about this.
Okay, yeah, getting a little freaked out, but in a good way. Knowledge is power and all that. Which is where our listeners' research comes in, right? They sent over a few studies on diagnosing ARVD. One of them, P1391-PDAF, even has this whole case study about it.
Oh, yeah, that one's really something. It's about this 32-year-old guy, seemed healthy, ends up in the ER with horrible chest pains. Turns out that was the first real sign of ARVD for him.
Seriously. No warning signs before that at all.
Well, looking back, there were some really subtle things. Dizziness, shortness of breath sometimes, even tingling in his arm. But who connects that to their heart?
Oh my gosh, that's terrifying. It makes you wonder how many people are out there walking around, no idea.
Yeah.
Okay, this deep dive is already eye-opening.
It really is. Catching ARVD early is huge. Makes all the difference for treatment and everything.
Okay, so let's get into that. How do you even diagnose this thing? Is there a test?
If only it were that easy. It's more like putting a puzzle together, honestly.
Like what kind of puzzle pieces are we talking about here?
So first off, doctors look at your medical history, family history, that kind of thing.
Makes sense. Genetics, right?
Yeah, it can run in families.
Yeah.
But that's not the whole picture, of course. They also use tests like an EKG, which measures your heart's electrical activity.
Okay, so they can see if your heart's doing the electric slide when it shouldn't be.
Basically. EKGs can be pretty telling.
Absolutely. And lucky for us, we've got the expert opinion of Dr. Barai, an emergency medicine consultant. He shared some amazing materials with us, including an EKG showing classic ARVD signs. We're seeing T-wave inversions, epsilon waves, and QRS widening.
See, those aren't just random squiggles. Each one points to a disruption in the heart's electrical activity, especially in the right ventricle.
So they only have warning signs then.
Exactly. Red flags on the EKG saying, hey, we need to take a closer look here.
Okay, let's decode these red flags using Dr. Barai's list. First up, T-wave inversion in leads V13. But without RBBB. Now, I'm no cardiologist, so what exactly is RBBB and why does its absence matter?
Great question. RBBB stands for right bundle branch block. It's like a roadblock in the heart's electrical pathway, specifically on the right side. In ARVD, we see those T-wave inversions without RBBB, which helps differentiate it from other conditions.
So it's a clue that points us towards ARVD.
Exactly. Helps narrow things down.
And speaking of clues, Dr. Barai calls epsilon waves the most specific finding for ARVD. Why are these tiny waves such a big deal?
Think of epsilon waves as a hidden signature. They're subtle bumps on the EKG right after the QRS complex, especially in lead V1. They're like a fingerprint for ARVD.
A fingerprint, that's a great way to put it.
But here's the catch. They only show up in about half the cases. So while they're a strong indicator, not seeing them doesn't rule out ARVD.
So it's like having a secret password that only half the people know.
Exactly. You got it.
You mentioned QRS widening earlier, specifically in leads V13. What should we be picturing here, and what makes it different in ARVD?
Imagine the QRS complex as the part of the EKG that shows your ventricles contracting. In ARVD, the widening is localized to leads V13, meaning the right ventricle is taking longer to activate. Other conditions might show widening everywhere, so this localization is key.
So it's like a map, and these leads tell us exactly where to look. Okay, next up, prolonged S-wave upstroke. Why does this subtle change matter in ARVD?
Even small changes can tell a story. A prolonged S-wave upstroke, especially in leads V1-3, suggests the electrical impulse is taking a detour in the right ventricle.
Like it's taking the scenic route.
Exactly. And that detour takes a bit longer, which shows up on the EKG.
Fascinating how these tiny details add up. Now let's talk about ventricular ectopi. What's happening in the heart when we see this?
Ventricular ectopi is basically an extra heartbeat coming from the ventricles instead of the heart's natural pacemaker. It's like a skipped beat. Most of us experience them harmlessly, but in ARVD, these extra beats often have a specific pattern called LBBB morphology, meaning the electrical impulse is taking an unusual route.
It seems counterintuitive that we're talking about left bundle branch block when ARVD affects the right ventricle. Can you explain that?
You're right. It seems odd. Even though ARVD primarily affects the right ventricle, the electrical abnormalities can resemble a block on the left side. It's all about how interconnected the heart's electrical system is.
So one change can have ripple effects throughout the entire system.
Precisely.
And the frequency of these PVCs, the premature ventricular contractions, plays a role too, right?
Absolutely. More frequent PVCs, especially with that LBBB morphology, mean a higher risk of complications.
And finally, there's VT, ventricular tachycardia, often showing the LBBB morphology. How does this arrhythmia fit into the picture?
Ventricular tachycardia is a rapid heart rhythm that's potentially dangerous. When it consistently shows that LBBB morphology, especially starting in the right ventricle outflow tract, it strongly suggests ARVD.
So, to sum it up, while ARVD is serious, early detection through EKGs can be a game changer.
Couldn't agree more. And this brings up a crucial point: family history. If anyone listening has a family history of sudden cardiac events, especially in young people, talking to your doctor about ARVD and genetic testing is vital. Early identification can make all the difference. But here's the thing. EKGs aren't foolproof. Arrhythmogenic right ventricular dysplasia.pdf, one of the studies you sent, it talks about these major and minor criteria they use, along with the EKG.
Criteria. So, like, is my heart getting graded or something?
Not quite. It's more that an EKG might show something weird, but it's not always a clear-cut you have ARVD situation. So they look at other stuff too, your symptoms, family history, other tests.
So they're like building a case file on your heart, trying to rule things out.
Exactly. And there are other tests too, like they might do an echocardiogram.
Oh yeah, those are pretty common.
They are. It's like an ultrasound for your heart. Uses sound waves to make a picture. That way they can actually see the structure, see if anything's off in that right ventricle, those weak spots.
Right. Got to check if the cardboard walls are holding up, metaphorically speaking.
Exactly. Or they might have you wear a Holter monitor for a while.
A Holter monitor. It rings a bell. What is that again?
It's like a portable EKG you wear for a day or two. Tracks your heart rhythm while you're just doing your thing, so they get a bigger picture.
So they're really building that case file. But okay, what about actually looking at the heart tissue? Wouldn't a biopsy give them a definitive answer?
You'd think so, but it's not always that simple.
Really?
Yeah.
Why not just go straight to the source?
Well, think about it. ARVD, it's like having those weak spots in specific areas, right?
The flimsy walls, yeah.
Right. So a biopsy, it's like taking a tiny sample from one little spot. You could totally miss the problem areas.
So you might get a false negative. Makes sense.
Exactly. Plus, anytime you're doing something invasive, like a biopsy, there's always some risk.
Right. Got to weigh the pros and cons. So let's say someone IS diagnosed with ARVD. What happens then? What are their options?
Well, the good news is it's definitely manageable. People with ARVD can still live long, fulfilling lives, especially with early diagnosis and the right treatment.
Okay, phew. That's good to hear. So what does treatment even look like for ARVD?
It really varies. Depends on how severe it is, what the specific symptoms are, the person's overall health, all of that.
So what, like a whole toolkit of options? What's in there?
Well, sometimes lifestyle changes are enough, especially early on, like avoiding really strenuous exercise, anything that could trigger those irregular heartbeats.
Right. Got to be gentle with those cardboard walls.
Exactly. But often, lifestyle changes alone aren't enough. That's where medications come in.
Okay, so what kind of meds are we talking about here?
They have all sorts of heart-regulating drugs now, help keep those heartbeats in check.
Keeping those electrical impulses from going rogue. But what if meds and lifestyle stuff aren't enough? What then?
That's when they might consider a procedure called catheter ablation.
Catheter ablation. Sounds kind of intense. What is that exactly?
It sounds scarier than it is. Basically, they thread this thin tube, a catheter, through a blood vessel in your groin, all the way up to your heart.
Wait, the groin. To the heart.
Yep. And once it's there, they use radio frequency energy to zap away the tiny bits of heart muscle that are causing the trouble.
So they're like doing microsurgery on the electrical system of your heart?
Pretty much. It's actually minimally invasive, so people recover pretty quickly.
Wow, technology is wild. But I'm guessing there are still some cases where it's more complicated. What happens then?
You're right. There are always those more complex cases. And for those, there's another tool in the ARVD toolkit, an implantable cardioverter defibrillator, or ICD for short.
An ICD. Okay, I've heard that before. But remind me what that is exactly. Like a pacemaker or something?
Kind of similar, but way more high-tech. Think of it like a bodyguard for your heart. It's this tiny device. They implant it under your skin.
So it's always there, keeping watch.
Always. It's constantly monitoring your heart rhythm. And if, God forbid, it detects something dangerous, a really bad arrhythmia, it can actually shock your heart back into a normal rhythm.
Ooh, seriously. That's incredible. So it's like having a defibrillator on the inside.
You got it. It can be life-saving, literally, for people with severe ARVD.
That's amazing. Okay, so we've talked about all these treatment options, from lifestyle changes to, like, actual heart surgery. But what does all this mean for someone's life expectancy after an ARVD diagnosis?
That's the big question, right? And I'm happy to say, with the right treatment, most people with ARVD live long and healthy lives.
Phew. Okay, good to know. It's easy to get caught up in all the scary stuff.
Totally. It's not a death sentence, but it does mean you need to be proactive, work closely with your doctor, that whole thing.
So, like any chronic condition, it takes management. What does that even look like for someone with ARVD?
Regular checkups, for sure. Got to catch any changes early on. And being really open with your cardiologist, any weird symptoms, anything at all.
Right, communication is key.
Yeah.
Well, this has been an incredible deep dive. We've covered so much ground today, from those sneaky ARVD symptoms to the whole diagnosis maze, A&D, all the treatment options. It's a lot to take in, but super important stuff.
It really is. And hopefully it empowers people to advocate for themselves, ask the right questions, really be in charge of their heart health.
Absolutely. And, it makes you think. Knowing what we know now about ARVD, how common it is, how dangerous it can be, but also how treatable it is. Should we be doing more to screen for it, especially in young athletes, since they seem to be at higher risk?
That's the million-dollar question. There's no easy answer. It's complex, ethical questions, costs, all that. But these are the conversations we need to be having.
So true. Well, on that note, we'll leave you all to ponder those big picture questions about ARVD and the future of heart health. This is definitely something to talk to your doctor about, by the way, not just listen to on a podcast. And as always, thanks for joining us for another fascinating deep dive. We'll see you next time.